I appreciate everybody being here. I know you get lots of opportunities to see things on Zoom, and this is a really important topic, but there are many of them out there, and I appreciate your sharing time with me and us on this. What I want to do is start off with the idea that a lot of interventions are have high hopes. We have high hopes for them when they're put into place. And this quote is from Laura Levitin, who was a senior evaluator at Robert Wood Johnson Foundation. And in her experience with many, many interventions and multi-site interventions, she has this quote: "My impression is that there is a normal curve of program success in multi-site interventions, with some sites doing very well, most sites doing mediocre, and some sites that apparently wasted all the time and money that they got." And this was said even in good times, let's say January of 2020, pre-COVID times. All of us who are involved in interventions now, whether they're experimental interventions or putting a program, a policy into place in one setting, we know how difficult that is even in pre-COVID times. And then COVID hits, and what happens there? So I want to address issues about implementation and how we can improve implementation and more likely get success. So some possible solutions in actually reaching outcomes include using evidence-based interventions, things that work, how implementation science, and I'm going to particularly talk about being ready to implement, can help in implementation. And then how can we build the capacity of organizations and communities to implement evidence-based interventions, and have a heavy emphasis on the idea of technical assistance. How can we support organizations in doing something new? So this is a version of the description that you signed up for. We talk about improving TA, improving readiness, and I'll talk about how to step over the gap between research and practice. There's a common idea that it takes 17 years to go from research to practice, and that's just much, much, much too long. What can we do to improve that? So in the course of today, I'll be talking about a new evidence-informed framework that we've been developing on TA engagement, technical assistance engagement, and also the work we're doing on something we call R equals MC square, which is an organizational readiness approach, and how we approach building the readiness of an organization or a community to implement something effectively. So, brief story. You know, as I said, even in normal times, even let's say January 2020, implementing programs, policies, practices with quality has been tough. And then we get things even tougher. So the project I'm going to feature in this presentation deals with the opioid crisis, but the topic and the ways of approaching the crisis and what can be done in an intervention, I think, apply to those of you who might be in the education area, in the health area, in the child welfare area, in just about any area that's interested in putting interventions into place, and in particular, evidence-based interventions. So back in January 2020, we were involved in a project in one state that had 10 substance abuse treatment centers. And the idea was to do evidence-based interventions. And there were two well-known evidence-based interventions that these centers were going to be trained on to use in their substance abuse treatment. One is called motivational interviewing, and the other is called cognitive behavior therapy. So this project starts up in January. It's supposed to take 8.5 months, and actually does. There's 8.5 months of funding to provide training and technical assistance so that these centers can do that. And then in March, as we all know, COVID hits. And so what happened? what happens to these interventions, what happens to building readiness to do those interventions, and how can technical assistance play a role in this? And that's the story, but it doesn't have to be just this particular instance. Any of you dealing with interventions now know that life has become difficult since March 2020. So in this state, as the opioid crisis has led to many, many casualties recently, and as we know, substance abuse has gone up since COVID, and so the problem hasn't gotten any better. So how do we approach this? So one of the things that we've done, and Maria mentioned this, is I've been involved with CDC and other colleagues in developing the interactive systems framework for dissemination and implementation. How can we do a better job of getting good stuff that's been developed in research actually used by clinics, by hospitals, by schools, by substance abuse treatment centers, any kind of what we call delivery system. So we have 3 systems in the ISF, the Interactive Systems Framework. One is synthesis and translation. With all the articles, let's say on substance abuse treatment in terms of what works, what do we know about what works? Is there a synthesis of that literature so that a clinician doesn't have to go and read hundreds of articles? And if there's a synthesis, has it been translated in a way that a practitioner can use? So that's what the bottom box is about, is having that useful information about what works and putting it out there in useful manuals or other kinds of forms of communication that's translated to be user-friendly for the practitioner. The top box is the delivery system, the hospital, the FQHC, the school, et cetera. They are the delivery system. That's where the action is. That's where, if things are going to make a difference, that's where they have to happen. And then the middle box is a support system. There may be great manuals available for purchase or on the web. How do they actually get used? Are there trainings? Are there technical assistance? That's what the support system's about. And a lot of what I'll be talking about begins to fill in this framework. So readiness. In order to be ready to do something new, a person, an organization, a community, a state has to be willing. You have to have motivation, and you have to be able. You have to have the capacity to do this thing. And an innovation is a program, practice, or policy that's being implemented in a setting. And we often think about them as new programs, practices, or policies. And we know from the literature that readiness is critical for quality implementation. So what's involved in being ready, what's involved in motivation, and what's involved in capacity? And we use something called R equals MC squared. Readiness is a function of motivation times general capacity times innovation-specific capacity. And what's that about? So in this next slide, we talked about the innovation. So in the story that I'm telling you about, the project I'm telling you about, we're bringing motivational interviewing and cognitive behavior therapy into 10 substance abuse treatment centers. And if we look at the middle box, innovation-specific capacity, that's what most training is about. It's how do we teach people in a workshop or a series of workshops the new skills that they need to do this new thing. And a lot of times those trainings are what some people in education call one-shot Marriott. Some trainer comes in from outside for a 2-day workshop or a 3-day workshop, dumps it into people's heads, and somehow it's going to get used. And what we know from the literature and the way we've synthesized the literature is it takes a lot more than that. In order for something new, like cognitive behavior therapy being incorporated in substance abuse treatment, that center, that organization needs to have a program champion behind it, somebody who's influential who says, I know you have 50 things on your plate, but I'm really watching this. I'm going to help you make this happen. Is there a supportive climate? Has the organization provided the time off to get the training? Have they provided the software and the various kinds of things necessary to put the innovation into place? And then a lot of changes involve inter-organizational relationships, collaboration between organizations. That wasn't as much a factor in this particular project, but intra-organizational relationships was key. Were the leaders really on board? Were the middle management really on board? Or did they just expect the frontline people to learn it and do it? And then there are a lot of units, the admissions unit and the treatment units, that need to coordinate to do that new thing. So you can see that capacity has a lot more than just building people's knowledge and skills. And then if you move to the left, there's also the motivation to do something new. So you can have the capacity to do something new, but you have a lot of things on your plate. What's really happening? Is there a drive? Is there a momentum to move this forward? Relative advantage. If that organization already thinks they're doing well in substance abuse treatment, bringing in something new, they may not be all that motivated to do it. How compatible is this new thing with how they ordinarily work? If it involves a big paradigm shift, it makes it less easy to be motivated. How simple or complicated or complex is this new thing? A lot of interventions that we try to put into place have lots of parts, they're interdependent, and they can be hard to learn. Observability. Can you start to see a return on your investment in the short term, or do you have to wait 3 years to see any change? Ability to pilot. Can you start this a little bit at a time, or do you have to stop everything to do it? And then last but certainly not least, is this new thing a priority? Is it mandated or required, or just another nice thing to do of the 50 things you've got on your plate? So motivation and innovation-specific capacity are about the particular new program, practice, or policy that we're trying to bring in. Then on the right, there's the everyday working of that organization. Some organizations are running smoothly day to day. Others are in crisis. It's like their head is just above water every single day. And if they're in crisis, if they're not functioning well, if they're not a healthy organization, it's hard to bring something new in. And we talk about the general capacity of an organization, its culture, its climate, its ability to do new things, its innovativeness, its structure, its hierarchy. Are the leaders really on board and pushing for this? Does the organization know how to use potential resources? And what's the time, energy, and experience of the staff? These are the things that help make an organization ready to do something new, and it's multiplicative. If any of these are zero or near zero, you can have all the motivation in the world, but you have almost zero innovation-specific capacity, you're not going to be ready. Anything times zero is zero. So how can we provide support? We know that everybody feels like they're busy all the time when they're on the front lines, when they're in a delivery system, when they're in a school, when they're in an FQHC, when they're in the emergency room or in a hospital setting. How do we help people in the organization learn to do this new thing? And that's that middle box I was talking about before, the support, technical assistance. So how do we provide technical assistance? Well, a metaphor I like to use is teaching somebody to drive. People don't learn to drive by picking up a book from the State Motor Vehicle Bureau that says, here are the rules of the road. You know, those books are helpful, but they're not sufficient. So we give people, oh gosh, this, I'm sorry, this was mixed up. Training is down here. We put people in workshops, and lots of times in the workshop, everybody gets the same thing. Sometimes that workshop has somebody who's brand new on the job, and another person's been on the job for 10 years, and they all get the same training. So training is cost efficient, but not necessarily cost effective. That gets followed by technical assistance, where somebody is teaching the person how to drive on a rural highway, and that's different than when you drive in downtown Houston versus different when you're driving in an interstate. And technical assistance tries to be individualized when you're teaching somebody how to do cognitive behavior therapy and they're a supervisor versus teaching a frontline person how do you do cognitive behavior therapy. And the last one is quality assurance, quality improvement. And that's the driver's test. That's making sure that this person really knows how to do it, that the skills are really there. It doesn't just stop at training. So I apologize for those not being in order. So when an academic takes that metaphor and puts it into a logic model, this is what it looks like. And this is what it looked like when we applied it in this project with substance abuse treatment centers. We know that the 10 centers aren't all starting out in the same place. Their general capacity and their motivation, even though they agreed to be in the project, they're not all in the same place initially in their current level of capacity at the beginning of the project. And their motivation might be different as well at the beginning of the project. So they can get tools, they can get training, and there was a strong period of training, several sessions, followed up by technical assistance, weekly meetings for technical assistance on how to apply the training. And there was also quality assurance, quality improvement. So they actually had to submit sessions that they did. The new clinicians who were new to the project had to submit transcripts that were reviewed and feedback was provided. And that's the kind of thing that needs to take place in order to get something new to really be implemented with quality. What we've done is try to move these tools, training, TA, QI, QA, to be evidence-based. Not all tools are of equal quality, not all training is of equal quality, not all technical assistance and quality improvement, quality assurance is of equal quality. And we're moving to try to make those evidence-based, and I'll describe that in a moment when I talk about how we do our technical assistance. What I do want you to see is also it's surrounded by relationships. We know particularly when you're doing technical assistance, and even more so if you're in a quality assurance, quality improvement mode, that your relationships between the provider and the recipient are really key. If there's not trust and respect, this thing's going to break down. So when we do this work, we talk about building readiness. You know, they're starting off, they're learning about cognitive behavior therapy, they're learning about motivational interviewing, they really didn't know much about it before things started. So there's a period of initial engagement that we work on with our technical assistants to build readiness. We do a readiness assessment of all of those what we call subcomponents, all of those parts of R equals MC square. We have a survey that has psychometric properties that we use to assess that. We provide each of those 10 centers with a readiness report about where they're high, where they're low, areas that they might want to prioritize to really be ready to implement motivational interviewing and cognitive behavior therapy. And we couple those areas where they want to strengthen with change management strategies that include intervention mapping in the way they're conceived, and that this eventually moves them to higher implementation outcomes. So I've described that our technical assistance approach tries to build readiness. They get a readiness report. And what we've been doing with technical assistance is really trying to up the game on technical assistance and make it evidence-based. We take the approach that if it's important to be evidence-based in our interventions, it's also important to be evidence-based in our technical assistance and in our training. Not all technical assistance is of equal quality, not all training is of equal quality. How can we really improve that? And we've been looking at 4 areas to improve. One is we've developed an engagement technical assistance framework. We're also looking at the readiness of a technical assistance recipient to actually receive technical assistance. And we look at evaluating technical assistance, seeing how well it's going and where it needs to be improved, and the extent to which there's TA engagement. I'm going to describe this in a little bit more detail because we think technical assistance is extremely important. There are literally billions of dollars spent on technical assistance each year. And yet there's relatively little known in the literature, relatively little systematic knowledge about technical assistance, relatively little systematic evaluation of technical assistance, other than did you like your technical assistance provider and a couple of happy face kind of TA questions. We're looking much more deeply at what technical assistance is like. And we're reviewing the literature, and we have come up with a TA engagement framework. And we realize that if you look at the bottom, that there are different phases of TA. Starting off the TA, preparing for the TA, then the actual plan for TA, then moving into implementing and evaluating TA, and then some kind of sustainability so that when the grant, for example, stops or that funding stops, what happens? And what you see in the right-hand side is the importance of relationships. This can't really be done well unless there is trust, unless there's respect, unless there's a collaboration that makes the technical assistance really meaningful, that there's adjusting to the different areas, the different readiness amounts of different recipients, that it's strength-based, that it's supportive, and that there's real communication and rapport. These things sound obvious. They don't necessarily take place in a systematic way. And that's what we're moving toward, is the systematization. We're also looking at the readiness for TA, that not all recipients are ready for TA. How can we assess their readiness? How can we build their readiness so that there's better interaction and collaboration? And then we're developing a TA engagement questionnaire. And what we're looking at there is how can we systematically look at what's going on in TA. And part of it is relationship-oriented. You can see the relationship dimensions. And part of it is the technical skills involved in doing TA. What we're doing is trying to take some of the mystery out of it, demystify TA. It's not something that happens, just in a room between two people and we can't understand it and study it more systematically. We know we can. And that's what we're trying to do in this survey that helps lead to improvement. So I want to move us into having each of you think about January 2020, think about an intervention, a policy, a program, a process, a practice that was either planned or was already started. And then February, March, April, May, June, July, August. What's happening? And we have started to think about that in March, and we have a manuscript going in for publication this week that describes what we call a readiness, resilience, and recovery tool. How can we deal with something that's disruptive? And it doesn't have to be as disruptive as COVID. It could be, a hurricane. It could be a fiscal crisis. It could be something really important, major change in leadership in an organization. Various things can happen. And as we thought about the projects we were working on in March of 2020, we started to think about, each project and what's happening. And some projects were moving ahead at 4/5 speed in March and April. They didn't totally stop, and they didn't slow down to even 1/5 speed. Other projects we were working on slowed down to 1/5 speed. And then others went into hibernation and hoped that come September, life would be back to normal. They wouldn't really have to change anything, and they could just resume their original plan. Well, we all know how that's worked out. So as we thought about what was happening with each of our projects, we decided we were going to step over the gap between research and practice, try to think about, from a readiness perspective, what was happening in each of the projects. And in our approach at the Wandersman Center, we talk about 3 strategic directions. We talk about developing tools for what we do. We talk about research and evaluation. And we talk about practical application. And we are aiming for the star in the Venn diagram from the get-go. And when we talk about stepping over the gap between research and practice and not waiting for the research to trickle down into practice, it's because we're starting off with real issues that we've seen. So if we go back to the COVID experience that I'm describing back in March of 2020 and thinking about each of our projects, we take a look at our subcomponents and we look at our priority, for example. What happened with our priority? So with the priority of bringing evidence-based interventions into these substance abuse treatment centers, well, maybe the priority shifted in March and April. Maybe doing any kind of service was going to be more important than bringing in something new. So where did evidence-based interventions fit in March and April if they could do any service at all? Some of these centers had to go from in-person to virtual. They didn't do virtual at all before. So their priority was to deliver a service and not necessarily this new initiative. So there are 2 parts to this. Has the priority of what you were interested in, it might have been colorectal screening, it might have been something else, has the priority shifted in that federally qualified health center? And whether the priority shifted or not, did the particular new initiative that you were bringing in or that was being brought in by leadership, what happened to that particular initiative? Did that go on pause? Did that get thrown out? And people just say that really wasn't, that's not a high priority for us anymore. We still think evidence-based stuff is important, but your particular initiative involves something new, and our clinicians are too tied up with what they already have that we can't really put that into place. And so we used our Readiness for Recovery and Resilience tool, and we looked across our 10 sites, and we found that priorities did change, that the compatibility of bringing in the training via in-person had to be changed, that staff capacity changed. People were diverted into other kinds of jobs, the people who were going to do it. People working from home just didn't have the capacity to do as much with something new. They might have had childcare issues, various kinds of things. Leadership might have changed. There might have been turnover, and that did happen. And leadership also changed the priorities. And then in terms of simplicity and complexity, bringing in training and technical assistance on motivational interviewing, cognitive behavior therapy, with supervision, with all that was involved, something that had seemed fairly straightforward looked much more complex after that. So I'm coming to the end here. I know I've talked to you about a lot of things. I'm doing a quick review here. This is deja vu all over again, okay? So we started with the idea that even in good times, it's hard to get interventions done with quality, and then what the possible solutions are. And we talked about the importance of technical assistance in helping do something new, and also the readiness to do something new. And I've been telling you one of the stories, one of the projects we've working on with the evidence-based interventions. We've talked about the interactive systems framework. The bottom is the good stuff that's coming from research about what works. The top is the delivery system, the FQHCs, the substance abuse treatment centers, And then, is there a support system that provides training and technical assistance? And then we moved into what readiness is, R equals MC squared, and then into how we think about doing technical assistance in a more intensive and evidence-based way. And then thinking about how readiness changed as a result of COVID, using the situation with the substance abuse treatment centers. And I will tell you that actually there's a lot of good news. Just this morning, we had the ending, kickoff. The project ends tomorrow, and all of the sites came on. And there was a remarkable amount of progress in spite of the barriers. The coaches used a lot of the readiness work in real time to be responsive to the changes, even though new barriers had come up. And so the support system of technical assistance and training made adaptations to actually make a lot of progress in readiness, in the ability to follow through and actually implement cognitive behavior therapy and motivational interviewing in those settings. And each of the sites reported on changes, positive changes that they've made. So it's not all doom and gloom. Being ready means being ready to change. It doesn't just mean being ready at the start of a race. The first one out of the gate is not always the winner, that you have to be ready all the way through. So the work that I've described, and I know I've gone through things really quickly, is based on the work of a lot of people at the Wandersman Center, and is based on a lot of work in implementation science and other literatures. A lot of what we've done in building the interactive systems framework and our readiness work builds upon the work of others. And I am ready to take comments or questions. What's important to me is not what I've told you, it's what you're taking away from today. And I know I've gone through things quickly. We will make the version of the slides available for people who want them. And over to you, Maria, for comments and questions.
Thanks so much, Abe. And it looks like we have several questions over here on the chat. And let's see, one of them that I see, and I'm going to read out a couple of these questions and then turn it over to Dr. Balasubramanian. Before I do that, though, I neglected to mention that this is the second of the series of webinars that we're having in implementation research as part of the Texas Institute for Implementation Science that's co-led by me and Dr. Bijal Balasubramanian, who will be taking over the questions in just a minute. So thanks so much. We have two other presentations left for this fall, and so I'm hoping that you all can join those as well. But thanks so much, Abe. This has been great, and let me just give you a couple of the questions. So first of all, someone asked, I'm curious, is the R equal MC squared model, in that model, what are the most essential components? I'm sure each piece is important, but have you found that there are any key variables that are essential without which the whole thing falls apart?
Well, we actually have an article that used a Delphi technique with experts to ask which of these we call them subcomponents under each of the three big categories, which of the subcomponents are most important at different stages in the life cycle of an intervention. So what's most important when you're just starting up? What's most important in the initial planning? What's most important in full implementation, and what's most important in sustainability? As much as I'd like to reduce the number of subcomponents, we have found that they all play a role. mean, clearly, priority, if something is mandated or required, that makes a big difference, a really big difference. Program champions turn out to be extremely important, and certainly supportive climate. If you just drop something into an organization and it's there to sink or swim on its own, without the organization kind of wrapping around and saying, I'm going to help you make this work, I'm going to give you the policies, I'm going to give you the resources, I'm going to give you the supervision that you need to carry this through, it won't go very far. And then again, if you're not a healthy organization, if you don't have a reasonable amount of functioning, and leadership, as always, is key. Not only the buy-in of leadership, but actually the active engagement of leadership. I would say those tend to come across as the most important. But really, while I'd love to reduce the number, they all seem to play an important role.
Maria, should I jump in here?
Yes, go ahead.
All right.
Yes.
Well, so there are, Dr. Wandersman, there is a related question to what you were just talking about, which is, are there tools and measures available to measure these components within the R equals MC squared framework?
Yes, there are. Thanks for asking that. So we have something we call a readiness thinking tool. It's available on our website for free. It's a really great orientation device for conversations. And then while there are many things that I could have said in the brief amount of time I had, what I didn't say that I would like to say now is that Dr. Maria Fernandez, is the PI on a 5-year NCI grant to more fully develop an R equals MC squared readiness assessment survey. We actually already have one. It's been applied in 15 projects. Each time it needs to get customized because the innovation is different each time. So it's not you can't use the same exact items. You can use a lot of the items are similar, but they need to be customized for each project because your motivation to do even cognitive behavior therapy could be very different than your motivation to do motivational interviewing, let alone something quite different. So the items need to get specified to put that particular new program into place. So we do have versions of that we've used in about 15 to 20 projects. And then we are real excited about the work we're doing with Dr. Fernandez on this 5-year NCI grant to develop an even more robust measure. And then the Readiness Thinking tool is freely available for download. It's on the Wandersman Center website.
Thank you. Then there are a couple of questions that are related to training and technical assistance and the similarities or differences between the two. So what is the difference between training and technical assistance? And one of our attendees was interested in getting a bit more detail about specific technical assistance in the opioid use, substance use example you gave.
Okay. So again, I'm sorry that these pictures got mixed up. So this is the training actually right here, and they're being trained to learn to drive using these computers. That can be useful. I've actually tried flying a plane on a computer, but I really would not want to pilot a plane based on that. And I wouldn't want people driving based on how they do in this workshop. And the literature is pretty clear in implementation science, and people at the National Implementation Research Network have really made a very strong point that I reinforce. which is that much of training does not transfer without technical assistance and coaching. That in order to go from this workshop to actual use, you need to be coached differently when you're driving, as I said, on an interstate versus driving in downtown Houston versus driving on a rural highway. And so the technical assistance takes the good stuff from the workshop and helps the person apply it. And what happened in the project I'm talking about is there was, the training was originally going to be in person, but had to be virtual. There's a huge amount of both video work, Zoom work, as well as homework in manuals on cognitive behavior therapy and motivational interviewing. And then, as I mentioned, there was a QA, QI, quality assurance, quality improvement, in which they provided transcripts of actual sessions. So these clinicians learning new skills provided transcripts that were then gone over by supervisors and experts in cognitive behavior therapy and motivational interviewing. Does that, hopefully that addresses the question.
Yeah, thank you. And it occurred to me that this conference and workshop series is kind of emulating exactly what you said. There's the training component, and then the workshop will hopefully provide some of that technical assistance. So that's great. There was another question about what can you do if during a multi-year project, the readiness shifts dramatically due to something like COVID?
Well, even in non-COVID times, you're going to get change. And, you know, it's one of the problems in my mind. I know that not everybody would agree with me with RCTs, in which there often isn't room to try to improve as you go. And there's sometimes reasons to stay with the protocol, but really there are also times to try to change a protocol to make it work in midstream. And that clearly has had to happen now. You know, the hibernation thing really hasn't worked in a lot of cases. Adaptations need to be made. But even when you don't have something as dramatic as COVID, you can still look at, actually I'll go back to this, you can still look at the different subcomponents and see whether things have changed. You know, we have an election coming up. That could be potentially disruptive, whether it's at the federal level or at the state level. There can be huge budget changes that may not influence every single intervention, but there are plenty of people and plenty of policies and programs that will be affected by something like that. So we don't see, and actually, I'm going to go to this slide here. The way we approach readiness is that it's willingness times ability equals readiness. And that's not the same as some manuscripts and articles are saying, ready to roll or ready, set, go. That's in their title. That's the idea that if you're ready at the beginning of the race, you're going to be there at the end. 5 years later, 3 years later, 2 years later, you're going to have succeeded. And we know that doesn't happen all the time. We actually see readiness as being applied all the way through, from readiness to start, readiness at the early beginnings, readiness in the middle, and a readiness to sustain if this is worth sustaining. So it's not the way people always think about readiness, but we are convinced that that readiness is dynamic and that it doesn't always get, you don't always get readier. Sometimes there can be dramatic shifts, as we've seen in leadership, in budgets, in turnover, that really make a big difference. And readiness can go down as well as up.
Sounds really intriguing and again, related to the measurement of readiness, because if it's changing midstream, important to measure it. So that's great. There are a lot of questions, a lot of interest in the topic clearly, but here are a couple other questions related to co-creation and co-designing. I lost the question here for a second. And the question is that the attendee is also interested in how co-design or co-creation fits into this readiness strategy. And the person's working with an organization to develop a web portal. And we know that so much of what we will design will depend on what the organization wants or needs. Could you comment on that, please?
Sure, that's a great question. And, there's different readiness even for co-design. It's a very attractive concept. It comes with complexity. It often takes more time. So people actually have to be motivated in order to get into co-design. And so a lot of times when we're talking about the motivation to do something new, let's say the motivation to bring cognitive behavior therapy and motivational interviewing into the substance abuse treatment center. Some of our coaching is to try to improve readiness in these areas. Well, by pointing out the relative advantage of doing cognitive behavior therapy or motivational interviewing, by trying to align it with what they already do, by trying to make it seem less complicated. So actually, these can be used if they're in co-creation by taking into account the things that serve as barriers or facilitators to moving forward. So we think that this can be used in human-centered design in order to help in a co-creation kind of approach. So I think in summary, I don't think we can automatically assume that everybody or every situation is going to be motivated to do co-creation. It takes time, energy, it takes longer, it can be more expensive, it can work better, but one has to realize some of the trade-offs that are involved. And these might help think about what the motivation would be for co-creation and also how to increase a motivation for co-creation by trying to take some of these into account and saying, even though it takes more time, you're likely to wind up with a better product. Or how it can be used to make things more complicated because the people who are the practitioners might help think of something that makes it more straightforward, more simple, and might come up with a better idea than the program developer who came up with 20 different modules in their program, and maybe they weren't all needed.
Right.
I'll stop there.
Thank you. Maybe there's time for a couple more questions. And here's an interesting one. Have you applied this model to removing an intervention policy or program that is no longer effective?
That's a great question. We have not had somebody come to us and say, here's money, can you take this away? That hasn't happened yet. The area of de-implementation in implementation science, I think, is really worthwhile. We do know that there are many practices that do not seem to be effective, and yet for some reason, they're fairly sustained. And it would be useful, and I think just as applicable, to apply this to de-implementation as to implementation. But the opportunity hasn't come up yet.
Right. Another question is, is there a systematic way to determine who can deliver an innovation with only training, or which folks can deliver an innovation with only training, and which folks need the additional technical assistance and coaching opportunities to deliver the training?
Well, that's where, and again, I apologize. Well, let me go to this slide. that's where the QA comes in. If your clinicians that you're training to do cognitive behavior therapy and motivational interviewing can do extremely well on according to the QI you have and don't need coaching, that's fine. You can skip that step, but I think that's rare. And there's nothing new about these. We didn't invent these components. This is what happens. I know there are physicians and students in the audience. This is what happens in your training. You get tools, you get training, you go to classes, you get one-on-one kind of supervision, and then there's various kinds of tests, whether they're PhD defenses or they're medical tests to, get your license or whatever. So can you skip over this step? It's an empirical question. I don't think it happens very often. What I do want to point out while I have this slide up, when we're talking about an evidence-based system for innovation support, we didn't invent any of these components. What we have been advocating for and trying to do work on is making them evidence-based. Again, the idea that not all technical assistance is of equal quality, not all training is of equal quality. And the work that I described on technical assistance is how we're trying to make the technical assistance more evidence-based. So thanks for that question. Good question.
So we're at time, and I want to thank you, Dr. Wandersman, for a really thought-provoking and interesting presentation and the time that you kept for answering all these questions. So really appreciate that. And thank you, everyone, for attending. Just to remind you that we will have our next session on hybrid designs by Dr. Jeff Curran, and we really encourage you to attend. Thank you again. We look forward to seeing you at our next webinar. Thanks, Dr. Wandersman.
My thanks to everybody for tuning in.
Okay.